incidence is about 500 to 1000 per million population, and 30 to 50% of peripheral arterial obstructive disease patients are symptomatic. 15 to 30% patients with lower extremity arterial disease will progress from intermittent claudication to critical limb ischemia in coming 1 year. And very interesting, about 50% of these, the patients who have amputations are diabetic and have severe peripheral vascular disease. And only about half of the patients will be alive without major amputation 1 year after the onset of critical limb ischemia. That is, 25% would either have an amputation or would die because of severe coronary artery disease or carotid artery disease or atherosclerotic disease somewhere else. Next, please. Now, in summary, I've just pooled outcome, 6 months outcome from 19 studies of patients of critical limb ischemia. And it's very interesting to see 45% of these, only 45% of these would be alive without an amputation after 6 months. 20% would be dead because of severe atherosclerotic disease anywhere else. And 35% would be alive but would be having an amputation. Next, please. Now, coming on to the clinical presentation, the occlusive disease is very common. And in lower limbs, the most important thing is it's usually at multiple levels. It's a severe occlusive disease at multiple levels. And this often is a manifestations of severe atherosclerosis in different vascular beds. And this arterial insufficiency leads to skin breakdown, tissue loss, ulcer or gangrene, or foot pain at rest. And if you see, most of these patients who present to us would be either in Fontaine stages 3 and 4 or Rutherford stages 4, 5, and 6. Next, please. How we diagnose clinically? Of course, we see that the patient gives us a history of claudication or has a non-healing ulcer or a gangrene or a cold feet. But apart from that, when we do an examination, we always do an ankle brachial index, and it helps us to establish the diagnosis of severe peripheral vascular disease, and also gives us an idea about the severity of the peripheral vascular disease. The normal ABI is 0.9 and above to 1.1, and anything less than 0.4 signifies a critical limb ischemia, and anything less than 0.2 is actually a sign that the patient may have an immediate amputation. There are, however, few limitations to ABI, especially in diabetic patients who have non-compressible vessels. The ABI detection may be difficult, and we may get false results. Now, once we have a patient of claudication or a gangrene or an ulceration, and we have a low ABI, we do a CT or MR angiography or a catheter-based angiography, and this helps us to assess the extension and the severity of the disease, the outflows and the presence of collaterals, the runoff vessels, and the presence of thrombus and calcification. Next, please. Now, this is a correlation between the clinical manifestations and the ABI. Anything above 0.9 is a normal patient. In a claudicant, you usually have an ABI of 0.6 and up to 6 to 0.9. In patients who have wrist pain and ulcerations and a non-healing ulcer, the ABI is around 0.4. And in patients who have who are about to go an amputation or have non-viable limbs, the ABI is about 0.2. Next, please. Now, coming on to the indications of angioplasty and stenting or endovascular procedure in these patients. If we have a patient with Fontaine 2B claudication, we have a non-healing ulcer, or if we have a limb which is limb which has a impending gangrene, then we take these patients for intervention. Next, please. And these patients would have a temporary temperature loss, would have a pallor and loss of capillary filling, will have sensory loss and motor paralysis. Next, please. And this is also associated with diseases in vascular and other coronary beds and other comorbidities. And together with all these comorbidities, we decide whether there is a limb-threatening ischemia and whether the endovascular treatment is the right treatment and the first treatment of choice in these patients. Next, please. Now, there are some basic principles which I'm going to take you through for a lower limb intervention. We divide the lower limb vessels arterial system into above inguinal ligament and below inguinal ligament circulation. And the below inguinal ligament is we subdivide into above popliteal and below popliteal lesions. In above, please go back. In above inguinal ligament, if we have a stenosis of more than 70% or a gradient of 30 millimeter or more across the stenosis, or if the patient has a butter or limb claudication, or if the patient has a distal bypass, that means a fem-pop or an iliofem bypass, and the stenosis is in the proximal part of the inflow part of the bypass, then in these patients we go ahead and stent these arteries irrespective of the gradient which we find. Next, please. And this is done to increase the pressure head so that the distal flow improves. Now, in below knee vessels, we need to understand few points. If we have profunda and femoral artery, profunda is the most important artery for the lower limb circulation. It's not the superficial femoral artery. So that's number one. Number two, we have to be very aggressive in treating the proximal lesions. Even if we cannot treat the below knee lesions or distal lesions, if we treat the proximal lesions, we increase the pressure head and we can improve the circulation to the lower limbs. We should also avoid stenting over the joints and below in the lower one-third of the femoral artery and around the knee region, so that in these regions there is a lot of flexion and their stents are likely to get compressed or fractured. And another important point is that one leg artery is enough to prevent ischemia in the foot. And if there is an acute limb-threatening ischemia, if we can maintain a straight line flow right from the femoral to the foot, at least in one vessels, then we can take care of the ischemia and treat these patients. Next, please. Also, it's very important that below knee vessels are like coronary arteries. Their size is same. They tend to go into dissections and spasm, and it is treated in the same way as we treat, and with the same care as we treat coronary arteries. And here, the 2B3A receptor antagonists have a lot of role. Next, please. The procedures which we do are quite similar. It is angioplasty, which could be a luminal angioplasty, and in many cases it could be a subintimal angioplasty, which I'm going to discuss in future. And also it could be stenting, and the stents which we use are bare metal stents, self-expanding stents, drug-eluting stents, and covered stents. And in many cases, the lesions are because of thrombus, and here we do thrombectomy, thromboaspiration, and also a catheter-directed thrombolytic therapy. Next, please. Now, this is an interesting slide which also shows you new technologies which we use now in treating lower limb diseases. Now, if we have total long occlusions, we treat different types of atherectomy devices, which could be a laser atherectomy, or it could be a cryo atherectomy and angioplasty, or a Silverhawk device. And if it is the problem is a long total occlusion, we are going for a subintimal angioplasty. We have different techniques to re-enter after we cross subintimally the lesion. And the most important devices here are the outback catheter from Cordis, and also a Pioneer catheter, which is a combination of an outback catheter and plus an IVS at the tip, so that we can use an IVS to re-enter into the true lumen. We also have a lot of new devices in terms of a drug-eluting balloon, drug-eluting stents, bioabsorbable stents, and so on, which we may discuss later on. Next, please. Now with this overview, if we now coming on to the patient selection, the recommended FDA indications for doing a femoropopliteal angioplasty or stenting are task A and task B lesions, and task C and task D lesions, which involves lesions more than 5 centimeter in length, and chronic total occlusions, these sort of lesions are still better treated by surgery according to the FDA guidelines, but more and more of these patients are not being treated by endovascular means because of lower morbidity and good long-term outcomes and better technologies which are now available. Next, please. Next, please. Now, coming on to the femoropopliteal intervention, just to give you an idea, we have two approaches. The standard approaches are a contralateral approach, contralateral retrograde approach, where we go across the aortic bifurcation and then we treat the opposite limb. Now here the advantages are that we do not have to compress the limb which we are treating, so that the blood supply is maintained. When we are compressing after pulling out the sheath, we are not compressing on that limb, and the chances of stent thrombosis is very, very low. The other advantage is that we can treat very proximal lesions on the contralateral limb, which is the target limb, as compared to an ipsilateral approach, where it would be difficult because the sheath lines up into the proximal area. The disadvantages are that we get less pushability. We have to use balloons and catheters of longer shaft length, and the maneuverability of the catheter and the pushability is a little reduced. Next, please. The other newer approaches could be a retrograde popliteal approach or antegrade brachial approach. So these are other approaches with the new hardware. We can use these techniques to actually treat most of the lesions. Next, please. Now, this is one of our patients who had an acute thrombus in the superficial femoral artery. There was, as you can see here, the total superficial femoral artery is occluded. There was no need to panic or call a surgeon to do a Fogarty atherectomy or embolectomy. What we did is just passed in a catheter, a 7 French sheath. We pulled out, aspirated as much of the clot as we could. Then we left in a catheter with multiple side holes and infused tissue plasminogen activator. And that's the final result which we got in the femoral artery and below knee up till the popliteal trifurcation, where you can see absolutely clean arteries, and the patient had a viable limb and was discharged on the second day. So these patients do very well with a catheter-based treatment rather than a surgical embolectomy. Next, please. The protocol which we use is the standard McNamara protocol, where we use a TPA at a dose of 1 milligram an hour, or through the catheter, or urokinase at the dose of 2,000 international units every minute. We can use a continuous infusion of the lytic agent, or we can pulse spray the lytic agent about 1 lakh of urokinase every 5 to 10 minutes and wait and see whether the patient, the thrombus is lysing well or not. We can combine this thrombolytic therapy with thromboaspiration, as we did in the previous case, or a catheter-based rheolytic thrombectomy. And many a times, if the thrombus, we are worried about distal embolization, we can actually park in a distal protection device, especially the filter, and go ahead and do our procedure. Next, please. Now, this is another type of patients which we have, chronic long total occlusions. These are not the surgical candidates as of now, and these can be treated with good subintimal angioplasty. I remember about a year back, Dr. Arilan and myself, we did a long occlusion of the superficial femoral artery, doing a subintimal angioplasty and using multiple self-expanding stents. Next, please. And these patients do pretty well. I've already discussed about the femoropopliteal re-entry devices. I'm going to skip through this. This is a re-entry device by Cordis. And the other one is a Pioneer catheter with an IVS integration. Next, please. And we can also have a front-running device, the front-runner from Cordis, and the excimer laser devices, which can actually go and make a lumen into the atheroma